मम्मी खाएगी. Hi, Dr. Garima here, and today I'm sitting with my cute little son who's eating a very nice dark cocoa chocolate. Occasionally, I do give him so that he knows that he can get this at home and he doesn't have to eat it outside. Right? Right? So, yeah, we'll be solving another of Australian Dental Council SBQ. And coincidentally, this question came up for my today's solving. As just yesterday and today morning, there were few candidates who were confused between pulp sensibility test, pulp sensitivity tests, and pulp vitality test. They were thinking it's all the same. No, it is not. So I thought, no, eat it yourself. Thank you. So I am making this video. Of course, we'll be solving this question. But first, I got a very good presentation, which is explaining all these three tests and the differences, and about many other tests which a lot of graduate students have just heard of it, but don't know the actual significance or how it is done. So I would like you all to watch this video, and then we'll jump back to this question. Hopefully, this increases awareness of the pulp testing and clears the concepts as well.
The accurate diagnosis of the true histological status of the pulp is of significant importance for treatment planning. There are three terminology to understand: pulp sensibility testing, assess the neural sensitivity of the pulp; pulp vitality testing, assess the vascularity of the pulp; pulp sensitivity, condition of the pulp being very responsive to a stimulus. Neural sensibility tests, these are the tests that indirectly tell us about the vitality status of the pulp. They work on the principle of stimulating the neural fibers present in the pulp. These are thermal tests, which includes heat test, cold test, electric pulp test, EPT, anesthetic test, test cavity, thermal test. These tests involve the application of cold and heat to a tooth to determine its sensitivity to thermal changes. Heat test, materials used, electrical heat carrier, hot gutta percha stick, more than 65.5 degrees Celsius, others, hot water. Under rubber dam isolation, hot burnisher, hot compound, dry rubber polishing wheel, the area to be tested is isolated and dried, and a suitable lubricant, Vaseline, is applied and heat is directed to the exposed surface of the tooth. And the patient's response is noted. Heat carrier instrument that can deliver a controlled temperature to the tooth is preferable. Gutta percha sticks can be heated over a Bunsen burner flame until they are almost molten, at which stage they can be applied to the tooth surface. The heat is applied to the occlusobuccal third of the exposed crown. If there is no response, the hot substance can be moved to the central portion of the crown or closer to the tooth cervical margin. When a response occurs, heat should be removed immediately. If a heated ball burnisher is used, it needs to be heated over a Bunsen burner flame until the metal is glowing red hot. The instrument is then held about 1-2 mm away from the labial or buccal surface of the tooth so the heat can radiate from the instrument to the tooth. It is important to avoid touching the tooth surface, as the hot instrument will burn the enamel and leave a black spot. Mechanism of action: heat application for less than 5 seconds results in vasodilation, which increases intrapulpal pressure, results in reduced neural excitation threshold. Immediate pain or pain persist after removal of stimulus, result of irreversible pulpitis. Positive response similar to contralateral tooth is healthy pulp. No response is non-vital pulp. Cold test: endo ice, mixture of gases, CO2 snow, dry ice, pencil of ice, ice cold water under rubber dam isolation, ethyl chloride, dichlorodifluoromethane. Dry ice sticks were the most reliable cold test to use in most diagnostic situations. It is also the cheapest and quickest method of testing the pulp's reaction to a cold stimulus. The dry ice is formed in a device known as the odontotist. The temperature of the dry ice is approximately 78 degrees C. It is able to penetrate full coverage restorations. Tetrafluoroethane has a temperature of about 26 degrees C when first sprayed from the pressurized can, but this reduces to about 18.5 degrees C in the mouth. Mixture of gases temperature is approximately 50 degrees C and reduces to about 28 degrees C in the mouth. They are generally less effective than dry ice, especially when testing teeth with porcelain crowns. Cold application for less than 15 seconds. Positive response similar to that of contralateral control tooth, is healthy pulp, short sharp pain that disappears rapidly once the stimulus is removed is reversible pulpitis, an excruciating painful response that lingers on even after the stimulus is removed is irreversible, no response, non-vital. Electric pulp test. The objective is to stimulate a pulpal response by subjecting the tooth to an increasing degree of electric current. The electrode is placed against the incisal third enamel surface of the isolated and dried tooth crown using toothpaste as an electrolyte. The electrode is placed against the mid-third of the mesiobuccal cusp of molars and buccal cusp of premolars. Normal response. A positive response is a response that occurs at the same neural excitation threshold as the control tooth. Negative response. This denotes a non-vital tooth, which fails to respond even when the tester is set to the highest electrical excitation value. Early response. This denotes a diseased state of pulp as the tooth responds to a threshold which is less than that of the control tooth. Delayed response. This also denotes a diseased state of the pulp wherein the tooth responds at a significantly higher electrical excitation level than compared to the control tooth. False positive response, partial pulp necrosis, high anxiety, ineffective tooth isolation, contact with metal restoration. False negative response, calcified canals, recently traumatized tooth, immature apex, drugs that increase pain threshold, poor contact of pulp tester. Key points. The diagnostic accuracy of cold test is 86%, the electric pulp test is 81%, and heat test is 71%. Hence, clinically, a combination of cold test followed by EPT is recommended. Cold test is the most effective sensitivity test for immature permanent teeth. Anesthetic test. The objective is to anesthetize one tooth at a time until the pain disappears and is localized to a specific tooth, using either infiltration or the intraligament injection. Inject the most posterior tooth in the area suspected of being the cause of pain. If pain persists when the tooth has been fully anesthetized, anesthetize the next tooth mesial to it and continue to do so until the pain disappears. The anesthetic test is obviously a last resort test and has an advantage over the test cavity, during which iatrogenic damage is possible. Test cavity. It is performed when other methods of diagnosis have failed. The test cavity is made by drilling through the enamel, dentin junction of an unanesthetized tooth. The drilling should be done at high speed and with a water coolant. Sensitivity or pain felt by the patient is an indication of pulp vitality. Pulp vascularity tests. True vitality status can be ascertained only when we are able to assess the vascular or blood supply to the tooth. Laser Doppler flowmetry. Laser Doppler flowmetry is a non-invasive method of assessing and accurately measuring the rate of blood flow in a tissue. Laser Doppler flowmetry was developed by Tenland in 1982 and later by Holloway in 1983. Uses a laser source that is aimed at the pulp, and the laser light travels to the pulp using the dentinal tubules as guides. This principle is used to ascertain the presence of blood movement within the pulp space. The laser light is transmitted through a fiber optic source and placed onto the tooth surface. The light enters the tooth and gets absorbed by the red blood cells, which lead to a shift in the frequency of the scattered light. This occurs due to the Doppler principle. This shift in frequency does not occur in light that is absorbed by stationary objects. The proportion of Doppler shifted light is detected with the help of a photodetector. It is potentially used to differentiate a healthy, traumatized tooth with reduced blood supply from a non-vital tooth. Pulse oximetry is a non-invasive method to measure the oxygen saturation levels during the administration of anesthesia or other medications with the help of a finger, ear, or foot probes. Principle: the pulse oximeter sensor consists of two light-emitting diodes, one to transmit red light, 660 nm, and the other to transmit infrared light, 940 nm, and a photodetector on the opposite side of the vascular bed. The light-emitting diode transmits red and infrared light through a vascular bed such as the finger or ear. Oxygenated hemoglobin and deoxygenated hemoglobin absorb different amounts of red and infrared light. The pulsatile change in the blood volume causes periodic changes in the amount of red and infrared light absorbed by the vascular bed before reaching the photodetector. The relationship between the pulsatile change in the absorption of red light and the pulsatile change in the absorption of infrared light is analyzed by the pulse oximeter to determine the saturation of arterial blood. Dual wavelength spectrophotometry. Dual wavelength spectrophotometry is a method independent of a pulsatile circulation. The presence of arterioles rather than arteries in the pulp and its rigid encapsulation by surrounding dentine and enamel make it difficult to detect a pulse in the pulp space. This method measures oxygenation changes in the capillary bed rather than the supply vessels and hence does not depend on a pulsatile blood flow. Differentiates with reproducible readings between a pulp chamber of a vital and non-vital tooth, uses visible light that is filtered and guided to the tooth by fiber optics. Thus, unlike laser light, added eye protection is unnecessary for the patient and the operator. Non-invasive and yields objective results. Measurement of surface temperature of tooth. This method is based on the assumption that if pulp becomes non-vital, the tooth no longer has internal blood supply, thus should exhibit a lower surface temperature than that of its vital counterparts. Fanabund in 1985 showed that it is possible to differentiate by means of crown surface temperature, distinct difference between vital and non-vital teeth. Transillumination with fiber optic light. It is a system of illumination whereby light is passed through a finely drawn glass or plastic fibers by a process known as total internal reflection. By this method, a pulpless tooth that is not noticeably discolored may show a gross difference in translucency when a shadow produced on a mirror is compared to that of adjacent vital teeth. Plethysmography. It is a method for assessing the changes in volume and has been applied to the investigation of arterial disease because the volume of the limb or organ exhibits transient changes over the cardiac cycle. The same principle can be used to assess tooth vitality. Presence or absence of a waveform can indicate the status of the tooth. Radiation probe. Using xenon radioisotope. The tooth to be tested injected with xenon in saline. A lead shield placed over the tooth and radiation counts taken every 10 seconds for 15 minutes, using a small cadmium telluride radiation probe. Radiation counts detected from both vital and pulpless teeth. Pulpless teeth report relatively constant counts for the duration of the experiment, 200 to 300. In vital teeth the initial counts were much higher, 718 to 981. So in this video, we have covered pulp vitality tests with recent advances. Please subscribe our channel and hit the bell icon to get latest updates. Thank you for watching. Hello everyone, welcome to
So, hi, I'm back, and I hope you all have seen and understood. Let me go back to our question in detail about the pulp vitality testing from the other YouTube channel. They had just shot it very so beautifully uh, that I didn't feel like making a presentation of my own and sharing it with you all. I do really appreciate when someone else is doing a very good job of it. I would like to share their work, let them get the credit of it. And so long as it's helping to spread the right kind of knowledge. So after watching that presentation, you surely should not have doubts about the three types of tests that we were mentioning, correct? Now, jumping onto this question, I think a similar question I've already solved it before, but let's do it one more time. As I'm doing now question by question of each mock, so that it helps you all, and especially my enrolled candidates who are solving the mocks, and if they have any doubt for any of the question, they can just open the link and read through the extensive explanation that I provide. Because honestly, it's not possible to write a very detailed explanations for each of the questions. As I can speak more, I can show more here, and there are people like me who who learn better when they listen. Like I like to read, but I think I retain better when I listen. So I remember when I was myself appearing for my postgraduate exam, the final MDS, and we had one paper. There are four papers, theory, and one of the papers is preventive dentistry, and you have to like study that Soben Peters group. With all due respect to all those people who love that book, I mean, the preventive dentistry, like all those indices and biostats and those chi-square and pi-square statistics, etc. And which school health program is conducted in which year, in which country, etc. Honestly, I never got through it. And I mean, it was very difficult for me to grasp because I'm not a person who will rectify things, I will understand and I'll remember for life. But of course, I have to give that exam, I like it or not. I have to clear my MDS. So, what I did, all those school programs and statistics and indices, there's so many indices. The Perio itself has gingival index, you have your BOP index and whatnot. So I recorded it in my own voice and I used to play it 1 hour in the evening when I used to take a walk around my building. So I remember India is India, right? And Bombay, and everybody in the building knows everybody. So there were a couple of aunties in the building who used to always see me at that specific slot in the evening with my Walkman, taking a 1 hour round because the whole day when you study, you need some fresh air. And they used to be like, whenever they used to meet mummy, ये लड़की हमेशा कान में डाल के क्या सुनती रहती है? Like basically, what is this girl doing by putting the earphones in her ears? And my mom used to be like, I don't know. I mean, she must be taking a break from her studies. And I was like, seriously, only if there were songs, they are not. And I cleared that paper with very good marks because when I listen, I retain things more. Also, I remember this very nice incident with very fond memories, as graduate students, this will bring up a lot of your own memories. You form groups of five, six people and you gel well really long. And those are your real friends, because still you have not become a professional, you have not graduated, you're still in college, and it's selflessness. It's not competitiveness. So everybody's in the same boat. So I had this 4 or 5 friends, and during the exams, we used to just hang over at one girl's place. And I remember we used to take turns to read. So I remember all four of them used to open the textbooks and read, and I used to be just lying on the bed or on the floor with my legs up on the bed, and I'm like, I'm listening. I don't want to open the book and read. I'm listening. So and I used to retain that better. So, anyways, shooting the videos, I know there is a term to it. There's a scientific term where people retain things better when they hear it out. So, yeah, one of the reasons to shoot the video, also, first of all, it stays forever on YouTube and you can access it at any time. And it's very great if you're just taking a walk and you just put on and you start listening to an explanation which you think you want to listen to. So, anyways, let's just start with this before it becomes a really long video. A 23-year-old female presented at your clinic complaining of a lesion involving her back tooth. 23 is a relatively young person. However, it is not painful. Great, and you're seeing the picture. Actually, for short in the picture, two things come in the mind. One, it can be like that chronic pulpitis, or second, the gingiva has overgrown in that cavity. But for that, the tooth has to be fractured somewhere for the gingiva to have access to grow and come in the cavity like this. If that is the case, sure, it's an extraction. But sometimes in very young people, where you have such a scenario, And if the crown of the tooth is little more intact, this is of course a completely destroyed tooth, but sometimes the crown is really intact and is just in the occlusal area, you'll see a nice pulpal overgrowth. In that scenario, you can actually save the tooth if the IOPA is nice. The lesion has been there for a couple of months now, and she avoids eating on that side. Couple of months, and it's not painful. So something is going on. The tooth responds abnormally to electrical and thermal stimuli and is not sensitive to percussion. Not sensitive to percussion means no periapical infection happening so far. You all know, I assume, that the pathology of chronic irreversible pulpitis. It's basically a low grade infection and the pulp is fighting back. It's an over exaggeration of the reaction of the pulp to carrier stimuli. And it can be easily treated if the crown structure is nice and the roots are nice and the patient is cooperative, and it usually happens in young people. So, assuming the IUPA indeed shows that it's pulpal related, you know the diagnosis is chronic irreversible pulpitis. Let's see what are the further questions. If you don't know what chronic irreversible pulpitis is or you have never seen in your career, please go on Google, watch it. The lesion is classified as straight away hyperplastic pulpitis. It cannot be pulp necrosis. If it was necrosed, it wouldn't have grown like this. Reversible pulpitis, no. Eruption cyst, no, the tooth is already erupted and it's destroyed. Eruption cyst will be a bluish, reddish covering over the crown of the tooth and the tooth will not be visible. Periodontal abscess, there is no abscess. This lesion most commonly affects patients who are young. By definition, it's related to young people. So it cannot be old or any other medically compromised thing because pulp has to be very healthy to fight back. Most common cause of such a lesion is low-grade inflammation. I already spoke about it. Chronic hyperplastic pulpitis is essentially, it is a proliferation of inflamed pulp tissue. I love such kind of questions when they come in the exam because they are just straightforward answers. There is no ambiguity, there is no confusion, there are no two options which are correct. These kind of questions are surely marked questions. By now, you know what are unmarked questions and marked questions in Australian dental exam. If you don't, go back to my video, just type and search the logic of unmarked questions in ADC, and I've made a video on how many questions are unmarked. Just go through that. So the answer of this question is chronic hyperplastic pulpitis is essentially a proliferation of inflamed pulp tissue. It is not necrotizing, suppurative, or very sensitive. What is the best treatment for this patient considering the overall tooth situation? Yeah, see again, what is the best treatment? You're reading this, right? One second, I'll just on the charger. Yep, I'm back. So, whenever a keyword like this comes as what is the best treatment, it means all the options given would be correct. So, don't jump on and start thinking, oh my God, all the options are correct. How I'm going to choose? What is the best? Focus on the best. That's the keyword. Root canal treatment, it's a very good option, but this tooth, the one which is present in this question, is completely destroyed. The lingual wall is negligible, the mesial wall is gone. One of the indications of not doing an RCT is in a grossly destroyed tooth where tooth structure is not there to save. So if the crown only cannot be saved, then what is the point of doing a root canal? I know you might say you can do post and core, but this is too damaged. The crown would not just be stabilized on exclusive post and core. There has to be some tooth structure left. In this particular tooth, it is not a good option to do root canal. Yes, but if all the walls were intact and like I mentioned, only a occlusal wall was destroyed and the pulp would have been like a cauliflower-like appearance over it. In that scenario, because all the walls would have been intact, you could have tried and done root canal and inform the patient that the longevity of the tooth is questionable. Don't expect it to stay for years and years still. It can stay, and whenever there is a fracture that happens, Because of the weakened tooth structure, uh, extraction would be the option of choice. But this particular tooth, for sure, RCT, not option. Surgical removal of the polyp, but what would that achieve? You still cannot save the tooth, right? Extraction, good option. Retrograde filling to seal the root, but that would be done if everything again on the coronal portion is great. So retrograde filling is not the right option of choice, any of the above. All the options are correct somehow, but the best option is extraction in such a scenario. Plus, the patient is young, so just extract and give the option of implant, RPD, FPD, and let the patient decide what she wants to go ahead with. So I hope this is clear, and please do write in the comment section how is your understanding now after watching that pulp sensitivity test video, and now do you feel more empowered as a clinician and that you would not make a mistake thinking that the electrical pulp testings are testing the blood flow, right? So the difference between the sensitivity, sensibility, and the vitality testings, correct? So just leave that in the comments. Thank you.